Best paper from Ophthalmological Society of West Bengal, progression of hydroxychloroquine toxicity after its discontinuation, by Dr. Subhrangshu.
A very good evening to respected chairperson sirs and respected judges, my colleagues and seniors. My paper is titled Progression of Hydroxychloroquine Toxicity After Its Discontinuation. I have no financial disclosure. Hydroxychloroquine and chloroquine are widely used in the treatment of autoimmune diseases like SLE, RA, and other related inflammatory and dermatological conditions. Newer applications include those in diabetes, adjunctive cancer therapy. Retinotoxic effects, we are all aware of the Bullseye Maculopathy, which is basically a layer of depigmentation parafoveally. This is infrequent in Asians who typically show early damage in a more peripheral pattern, and whatever be the damage, it is irreversible. What are the possible mechanisms? Primary damage is to the photoreceptors, mostly outer segment, with secondary disruption of the RPE. Binding of the melanin to the RPE, it concentrates and prolongs the toxic effects of the drug. And the macular localization of the disease does suggest that light absorption or possibly cone metabolism may play some role. Now, if we look at the AIOC2018 guidelines, it has recommended screening tests include automated perimetry and SD-OCT, and the frequency, yearly frequency after the first 5 years of medication. So the aim and objectives of our study is to assess the retinal status at inclusion along with progression of any morphological or functional retinal alterations over the next 2 years post cessation of hydroxychloroquine or chloroquine. So we took IRB approval and we included subjects who were on chloroquine or hydroxychloroquine for at least 2 years, but at the time of enumeration had been medically advised to discontinue the same. And all the subjects are normal fundus on slit lamp biomicroscopy with a +78D lens. All patients signed an ICF, and statistical analysis was done using SPSS and Microsoft Excel, and we did the student's t-test, chi-square test, ANOVA, and Pearson's correlation coefficient. The major exclusion criteria: prolonged more than 1 year daily usage of hydroxychloroquine at more than 7 milligrams per kg body weight, any clinically evident macular pathology, any other previously diagnosed ocular or systemic disease or drug intake that could possibly affect the optic nerve, visual field, or retinal health. So we examined the subjects at inclusion and 6 monthly for the next 2 years. We did a complete ophthalmological evaluation including +78D biomicroscopy, and prior to dilatation all subjects underwent 10-2 automated perimetry. We did the SD-OCT in all these subjects, and special note was taken of the health of the ellipsoid zone. Coming to the results. So there were 9 subjects who fitted the inclusion criteria. All of them were females. The average age at inclusion was 62 years, and in all of them the drug had been stopped 5 to 10 months prior to inclusion. And the average treatment duration ranged from 3 to 16 years. Fundus change at the end of the study period. Depigmentation was there only in 3 eyes, and no eyes had Bullseye Maculopathy. The SD-OCT changes showed ellipsoid zone disruption in few subjects, and we measured them manually with a caliper. 1 subject had a cystic change as is shown here. And of course in all the subjects there were an increase in the PSD at the end of the study period as compared to the time of inclusion. So this table summarizes the visual acuity change. Well, we see that the BCVA has decreased in all the subjects except 1 eye. Average decrease in BCVA was 2.55 ETDRS letters at 12 months and 4.05 letters at 24 months, and the results were statistically highly significant. Now, if we look at the ellipsoid zone disruption at inclusion, that is month 0, only 1 eye had an 82 micron disruption, whereas at the end of the study, more or less all the eyes had ellipsoid zone disruption, and the pattern standard deviation also had increased in all the eyes, and those in blue are the ones which showed a statistically significant increase. And if we look at the years of exposure, like this one patient marked out in red who had 16 years of exposure to the drug, had the worst BCVA change, the worst EZ status, and the worst PSD. And when we correlated all the values, we found a positive correlation. The strongest was the years of exposure to ellipsoid zone disruption at month 24, that's 0.7. And here we are correlating the ellipsoid zone disruption to pattern standard deviation at 24 months, And here also we are finding a positive correlation. So to conclude, data on long-term follow-up after cessation of chloroquine or hydroxychloroquine are limited. Ours is a prospective study with a study duration of 2 years. Older studies using visual acuity or visual fields as a parameter concluded that retinal function either remained stable, sometimes improved, and only occasionally deteriorated after cessation. However, more recent studies have also described progressive loss of retinal function as a result of the toxicity. Kellner et al. Showed that chloroquine retinopathy can progress over a long period of time after drug cessation, and Marmor et al. Showed that central vision can be preserved if outer retinal damages can be recognized before there are RP layer changes. So our study shows that there is a deterioration of BCVA after the drug is stopped. 72% had ellipsoid zone disruption, 61% had PSD less than 1, and there was a positive correlation between the various factors analyzed. There are limitations in our studies. Sample size is small. We could not calculate the cumulative dosage, and we have not dealt with multifocal ERG or fundus autofluorescence. However, our study goes on to recommend that those who are initiated on these drugs needs to be counseled accordingly, need for baseline and subsequent screening explained. Non-invasive tests like automated perimetry and SDOCC should be done yearly on subjects for screening, and earliest detection of outer retinal damage should warrant prompt discussion with the treating physician and the patient regarding replacement of the drug. Thank you.
Yeah. Why were these patients advised discontinuation?
Well, in most of the cases, the 7 cases, they simply stopped all medications, and in 2 cases, they were put on other medication, methotrexate basically.
For what reason? For an ophthalmic reason? Or
No, not for ophthalmic reason. We took only those patients who were being treated by the physician. They had been stopped these medications for medical reasons, not from
none of these patients had any ophthalmic damage at the time of initiation?
No, sir.
When they entered your study?
Only one subject had a 82 micron ellipsoid zone disruption. Clinically, on 70D microscopy, all the subjects were normal, no depigmentation even.
Yeah, but you know, the latest guideline says that SDOCT is not the correct, the end stage of your evaluation. You should be doing an FAF and autofluorescence, and you should be doing a multifocal ERG.
Right.
So, is it possible that these patients already had subclinical damage, and we know that chloroquine damage continues as per your own literature that you cited.
That's right, yeah.
Continues even after cessation if you have stopped the chloroquine after RP is damaged.
Right, sir.
That was the basis of the AIO statement.
That's true.
Is it possible that these were your patients, or are we stretching it too far?
No, these are all patients who had come to our institute at some point of time or the other. Actually, when we started the study, we had the 2011 guidelines with us.
Oh, right, okay.
So
understood.
at that point of time, that is a limitation.
Yes,
FAF and multifocal ERG came out in the 2016 guidelines.
Absolutely right.